So Tony had the great benefit and privilege to go to Glasgow University, where he did medicine and neurology, and then from then it was downhill all the way, or certainly down to London, and he then specialized in neuropsychiatry. But one of the great things about Tony is he's a great methodologist. So we have, well, sadly he's now gone, as you can see, gone to UCL, which is not really that far away. But we can have journal clubs on a particular journal, and everybody is very impressed with it. And we've got 5 minutes to go, and we're about to go home thinking this is a really important paper. And Tony just says in a couple of sentences how methodologically incompetent it is. Recently, I asked him, you know, as you get older, you begin to wonder whether you start talking nonsense as you begin to dement. So I asked Tony, once I begin to write nonsense, would he tell me? And he said, how would he know the difference? So anyway, Professor Tony David, expert in neuropsychiatry and the director of the Institute of Mental Health at UCL, which is doing very well, actually. Tony.
Okay, thanks very much for that nice introduction. And thanks very much for inviting me to Palermo and to this wonderful event. So let's see whether I can get this. So I was invited to talk about insight, which is my favorite subject, but in particular to answer this question, is insight in the brain? So as I'm going to try and explain this concept of insight that psychiatrists and psychologists use quite a lot, sometimes quite loosely, it has been studied in many different ways, including looking at neurological and neuropsychological correlates. So I'm going to concentrate on those aspects, although I will probably mention some of the other things as well. So the starting point is to compare neurological conditions with psychiatric conditions. So neurological conditions, you have weakness, sensory loss, and then cognitive deficits such as amnesia, personality change, going through to hallucinations and delusions. So the bit in the middle, both psychiatrists and neurologists are interested in. And then as you get to those classical psychotic symptoms, that's really psychiatrists' bread and butter. And the weakness and the sensory loss are more kind of objective. Another person can see that you're unable to move your limbs. Whereas if you're suffering from delusions or hallucinations, it's only the person's report that tells you that what their experience is. So then add on top of that the expectation that the individual somehow knows that what they're experiencing is abnormal. And we're asking quite a lot of a person. But what's interesting is that when you look at neurological conditions, you do have very striking examples of people being unaware or seemingly unaware of their disorder or disease. So the first example of this was described by Gabriel Anton, who was a neurologist from sort of Austria, Czechoslovakia, and he described this lady who calmly and faithfully said that she could see objects in front of her, whereas daily examination proved the opposite. So she'd say, there's nothing wrong with my vision, but she would walk around bumping into things, being unable to grasp a cup or a plate. So it was clearly blind, effectively, but somehow didn't realize that she was blind. And interestingly, when she used the wrong word for something, she instantly knew that that was a mistake. So it wasn't some general inability to monitor what was going on. It was a rather specific inability to detect her, in this case, blindness. And so this has become known as Anton's syndrome. So it's a form of lack of awareness of blindness, cortical blindness. And then a few years later, Babinski, who's a French neurologist of Polish extraction, he coined the term anosognosia, which is one that we're still familiar with today. And he described this in the more common scenario of a person with hemiplegia, and it's usually left-sided weakness, reflecting a lesion in the right cerebral hemisphere. And sometimes that very obvious and severe weakness seems to be unknown to the person themselves. And they will say, no, there's nothing wrong with me. My arms and legs are perfectly all right. And then you say, well, why is it you can't get up from that chair? And they'd say, well, I don't feel like it at the moment. I'm too tired. So make up something. But it doesn't seem as though the person is pretending. It seems a very genuine lack of awareness. So the idea is, well, is this anything like what we see in the psychiatric clinic, where a person has very florid delusions, they believe that they're Napoleon, but don't seem to realize that everyone else thinks they're just an ordinary person? Is that the same kind of thing? Well, at least it's a starting point. And when we study the neurological cases, we find that there is a sort of neurological signature. So in this case here, this is just a cartoon of the brain, and if you have cortical blindness, here, the lesion is usually in this sort of occipital parietal region. But if you have Anton syndrome, which is cortical blindness without awareness, you've usually got a larger lesion that's sort of also involving, this was occipitotemporal, and you get a lesion that's also involving the parietal lobe. And when it comes to hemiplegia, if you take on average people with hemiplegia, they've all got a stroke that affects this pathway here. This is the sort of descending motor pathway. But if you've also got lack of awareness of hemiplegia, you've got a much larger lesion that involves the cortex, again, usually the parietal cortex. So it suggests that every function has a kind of monitor attached to it. And if you knock out the monitor as well as the actual function, you end up with being unaware of your deficit. Okay, so again, let's see whether any of that can translate into psychiatry. So here's Bleuler. Everyone knows, I think, that he coined the term schizophrenia. He also coined the term autistic thinking. And it's nothing to do with what we now understand as autism, which was described about 30 years later. What he meant by autistic thinking was what we would call the encapsulation of delusions. So here's an example he gave to illustrate autistic thinking. A schizophrenic inmate of an asylum enters a county inn and can only be removed by force because he expects the Queen of Holland, who wishes to marry him, to arrive at any moment. He is a little ungainly creature without a single advantage of mind, body, or estate. Not very empathic. It's impossible that the Queen of Holland should know anything of this poor patient, because after all, we're in Switzerland. And if she did, he would be the last man she would wish to marry. He imagines something absolutely impossible, believes it to be reality. The contradictions to reality do not exist for him. So the same kind of seemingly obvious lack of awareness occurs in our patients with delusions as it does in the neurological case. So Are there any more analogies than that? Well, the first person to write about insight was this chap, Aubrey Lewis, who was sort of one of the founding professors of the Institute of Psychiatry at the Maudsley. And here he is when he retired. But when he was a young man, at the age of 34, he wrote a very nice paper about insight. And he noticed that other people weren't writing about it at the time. And he defined it as the awareness that one is suffering from an illness and that the illness is mental. Not just that there's something wrong with me, because that could be there's something wrong with me because I'm being poisoned or because people are against me. You've got to say there's something wrong with me and it's something to do with my mental health. And then he made this observation that it resembles some neurological syndromes affecting the frontal lobe, which in the 1930s was only just beginning to be understood as a part of the brain that is responsible for higher functions like judgment and awareness. And he went on to say that it requires quite a lot of cognitive processing and that it can be a painful struggle. So there's a sort of humanistic element to insight as well. It's not all just about cognition, which is a very important point, I think. So when I started thinking about insight, it seemed that it was a very complicated thing. It was one word, but it was used in lots of different ways, at least 3 different ways. One, as a general awareness of illness, like Aubrey Lewis's definition. And so you would ask the person, do you think there's something wrong with you mentally? Yes, I'm sick. I guess I was crazy. But then there's the more specific kind of insight into symptoms themselves, which I call the ability to relabel symptoms. So the person will say, yes, I hear these voices. They seem very real, but I know they're not really voices. I know that's part of my illness, for example. I get paranoid, but I know deep down there isn't anyone really following me. So at least when people are recovering, they start to show insight into specific symptoms. And then there's the whole issue of compliance with treatment or adherence. So sometimes we use that as a measure of insight. So we don't necessarily ask the patient about their awareness, but if they're turning up for treatment regularly, or accepting their medication, say, would say, well, they must have some insight, and vice versa. They may say all the right things, but then don't want any treatment. So we say, well, maybe they haven't got full insight. So insight, as I use it, is this at least 3 elements. This general acceptance that there's an illness, this specific ability to relabel symptoms, and also the belief that there's some kind of treatment or intervention, might not be medication, but some sort of biomedical fix. And if you have all of those, you have good insight. But this is just an illustration. It's not to scale, but it's just the way I try and understand insight, that there's elements to do with your culture, your personality. Some people are just very individual and they won't be told anything. Others are much more sort of go with the flow. There's something to do with executive function and general intellect that I'll talk about. It's obviously very much to do with delusions themselves. Obviously, there's a lot we don't know. Family attitudes are important. And what I've suggested here, that there is an element that's to do with neurobiology, but is it a tiny piece of the pie or is it larger? So how do we study this sort of a bit more objectively? Well, psychologists have become interested in this concept of metacognition. And the importance of this is that you can study metacognition, thinking about thinking, in healthy people. You don't have to ask them, are they aware of a disease or an illness, because they may not be suffering from a disease or an illness. But you can ask them to reflect on their perceptions, on their judgments, sort of take a step back and try and be objective about whether they're making the right decision. And perhaps that's a bit like insight. So you can ask any person, how can I be sure that my beliefs are correct and that my perceptions are real or correct? How confident am I in my judgments, etc.? And this can apply to any judgments. Whoops. And then you can go on to say to the patient, if you lack confidence in your judgments or if you're overconfident, is that something to do with your illness? And should you take treatment? But the first step is a question we can ask of anybody. So the way that this is studied in the lab, as it were, is you can present the person with various tests. They might be perceptual tests or memory tests. And then you ask for the person to make the judgment and tell you how confident they are that they've got the right answer. And the person's confidence is a very strong measure of metacognition, which in turn seems to be related to insight. So you can present two circles with dots in them and say, which circle has the more dots, left or the right? How confident are you in that? You can show a person a whole list of words and then show them two words and say, which one of these did you see before? So in this case, hook is on that list, so it would be this one. So let's try it. So which side has got the more dots, left or right? It's quite easy. What about this one? Who knows? Well, they're the same. But you might have been very confident, oh, it's definitely this one. And that would have shown that you had high confidence, but you had poor metacognitive efficiency. So does that have anything to do with what psychiatrists and psychologists say is insight? Well, a little bit. So these sorts of tests of metacognition, what this shows that in men, there's a strong correlation with what we call cognitive insight, which again is this ability to question your beliefs. So maybe they're correlated. And then this was a very early study looking at people with psychosis, first episode of psychosis in healthy adults. And the psychosis patients doing these dot tasks or the memory tasks were quite bad at it. They were quite confident, but they were getting the wrong answer compared to healthy controls. So it may be that this sort of metacognition battery does tell us something about the more clinically orientated insight that we've been discussing.
What about females?
Well, in this case, there was no correlation between the sort of how many dots task and your insight. So that doesn't mean they've got less or more insight. Of course, women have better insight than men. Everybody knows that. At least that's what my wife keeps telling me. So here is a study of these sort of dots tasks and memory tasks in people who've got brain resections for various reasons. And what's very nice about the paradigm is you can make the task as difficult or as easy so that everyone is scoring the same, round about 60 or 70% correct. So you can titrate the difficulty for both the memory and the perception tests. And you can match people on their confidence. But how justified is their confidence? That's this measure here. And it shows that people in the red have got anterior frontal resections, are bad at metacognition for the perceptual task. They do all right in the memory, whereas the people with the temporal lobe lesions are doing slightly less well on the memory test. So this is taking into account how good they are at the task. It's about how good they are at telling, at at understanding how good they are, if you see what I mean. And so these are where the lesions were, and it was particularly this medial frontal area, that if that was damaged, the metacognitive efficiency was impaired. Okay, so another way of understanding what is it that's going into insight, how much is to do with the brain and cognition as opposed to our culture and our upbringing. So this just shows you, this was just a very large first episode study, and here's sort of insight and awareness from the PANS. So this was severe impairment, this was no impairment. So you can see, first of all, that insight is kind of a normal distribution. It's not an all or none. And this is a summary score of cognitive tests. So the people with the most severe insight impairments had the worst cognition. And then when you do a meta-analysis, this is the line here that would be, there's no difference. So most of the studies show that people with insight have worse general cognition or lower IQ. And you can see there's 70 studies here. And although there's a few that don't find a difference, most of them do. And I must say, when you look at that, usually when you're writing a review article, the last sentence is, "We need more research." I think in this case, we don't really need any more research. Plenty of research, and it all points in the same direction. So there is something about IQ and insight. And when you look at not just general IQ, but more of these frontal or executive tests, there's not so many tests, but again, it's very clear that they're all on that side of the line. So, in other words, tests of executive or frontal lobe function they all show a correlation with clinical insight. So the worse your frontal lobe function, the worse your insight. Okay, what about neuroimaging? Because we're asked to say how much of this is down to the brain. Well, again, it's hard to study insight into illness in healthy people because they don't have an illness. But you can ask healthy people about their personality. And if you're asked, are you a shy person? Are you a weak person? Are you intelligent? It seems to involve the same kind of process. You think about yourself, you try and be honest, you look in the mirror, as it were, and you say yes or no. And the point is that if you do that while you're in the fMRI scanner, these are the bits that light up. The medial frontal, in this study also the posterior cingulate, but very much this medial frontal anterior cingulate bit seems to light up. So that seems to be the part of the brain that is active when you're self-appraising. And it's been called the cortical midline system. And this was a sort of meta-analysis of all those similar studies, about 8 studies. And when you put them all together, it's quite consistent. This is the area that lights up, and you can, on the sagittal view, you can see it's this medial frontal anterior cingulate sort of area that seems to be doing that work. And it's quite interesting because the most famous patient in neuropsychiatry is this chap called Phineas Gage. Don't know whether you're probably all familiar with him. He lived in 2 centuries ago in North America, and he had this terrible accident while he was working on the railroad, and a rod went right through his skull and out the other side. And amazingly, he survived, but his personality was irrevocably changed. And he went from being a hardworking, abstemious guy to a real hellraiser and party animal, and didn't seem to realize that there was anything the matter with him. So that kind of area, this medial frontal area, seems to be the area where we exert our self-awareness and self-control to some extent. And here's a more modern study of traumatic brain injury, which again just makes the point that it was these areas, this one, but also this one, that showed different levels of activity when the person was doing a self-appraisal task compared to a healthy control group. Okay, when it comes to structural studies of the brain, comparing people rated as having good insight or poor insight, there's lots of studies, and I stopped sort of collecting them after a while, and you don't need to pay attention to it. But basically, there's some negative studies that don't find any difference. There's some positive studies, but it's pretty much all over the place. So it's hard to draw any conclusions. But we did a study where we looked at insight in more detail using this sort of 3-dimension scale. And these were first episode patients, so they weren't chronic, hadn't had a time to show major brain changes. And we classified them into a low insight group and a high insight group, and looked at gray matter deficits using voxel-based morphometry. So that means you just ask the computer to tell you which bits of the brain are different between high and low insight patients, rather than starting off with a region of interest. And it picked out these regions here. So again, this is a coronal section through the brain, and this is the sort of front going through to the back. So again, it's this frontal medial, although also posterior area that seem to be different. And here it's a reduction in gray matter density in those areas. So the previous scans were functional scans, how the brain was working, but this shows that the hardware, as it were, is also slightly abnormal in the same sort of region in patients with rated as having low insight. And here is a more up-to-date meta-analysis of neuroimaging studies by Marika Pijnenborg from Holland, and taking all of the data that she was able to combine, finds that this overall, on average, there is this lack of gray matter volume is a feature of people with low insight, although this is just a sort of generalized effect she's finding in the meta-analysis. But when you look in more detail beyond just gray matter volume, these are some studies of the thickness of the cortex. And again, it's comparing patients with different levels of insight, and it's picking up areas of thinning of the cortex in the temporal lobe, in the lateral frontal lobe, but also in the medial frontal areas. So again, it's not really one area that's coming out, but several. And here's a very recent study from a Canadian group, and what they're looking at is, first of all, they're looking at patients with treatment-resistant schizophrenia, and then they're looking at, within that group, those who've got lower insight, clinical insight, and those who've got better insight. And what they're finding is that in this lower panel, the treatment-resistant patients with poor insight have thinner cortices in the frontal pole and the temporal pole. Not so much this medial frontal area that we were previously interested in. We can also look at white matter, and that seems to be related to insight. Harder to see, but some of these tracks here you can see with yellow and blue dots. These are areas of white matter thinning. So it's not just a gray matter, it's presumably the connectivity between areas that is affected in people who struggle with insight. So that was people with schizophrenia. You can look at other, going back to our original sort of starting point, starting with people with neurological conditions. You can look at people with neurodegenerative disorders, dementia, for example, and the same questions arise. Does the person realize that their memory is failing, that their behavior is deteriorating? And anyone who's looked after patients like this or relatives know that it is a really quite a difficult and fraught issue when the person you're caring for doesn't seem to be aware or realize what their problems are. And you find that if you compare people with various forms of dementia who have good awareness versus those who have poor awareness, the difference is those with poor awareness have worse gray matter, again in these medial frontal regions. These are very basal frontal regions, but you can see that it overlaps with the regions that we were interested in before. And in fact, this is, again, it's a kind of a meta-analysis of neurological studies, of dementia studies, where they've compared people with good awareness and bad awareness. And again, a lot of the brain is being implicated. And maybe that's not surprising. We're not expecting that there's kind of an insight center. There's one bit of the brain that's important because it's such a wide, broad part of life to think, you know, is there something wrong with me? Am I who I should be? It certainly does involve this medial frontal area, but it also involves temporal and lateral regions. So you only get a color if you're positive on 2 structural and 2 functional imaging studies. So it's quite a high threshold. But even then, a lot of the brain comes out positive. So there's still very few studies that looked at the functional imaging in patients rather than in healthy volunteers. And this was a study that we did a few years ago now. And we had healthy controls. So the test was, first of all, they had to look at a letter. Then they had to do an appraisal, not of themselves, but of another person. So we had to choose a person that everybody sort of knew or thought they knew, and then we'd ask them about themselves. So the other person was Tony Blair. So we asked people, is Tony Blair unstable, crazy, disordered, psychotic, evil, cruel, wonderful? There's no right answer. And then, are you unstable, crazy, disordered, wonderful, special, etc.? So it was very tightly controlled. The difference was, in one case, you're asking the question about someone else, and the other case, you're asking the question about you yourself. And what we find is, in the key comparison between me versus someone else, me versus Tony Blair, what is the difference between patients and controls? And it all boiled down to this region here, which is it's a medial frontal region. It's a bit higher up than some of the other regions that we've seen, but it's kind of in the ballpark. So what's happening in people with schizophrenia, they activate that area both when they're asking the question about the other and themselves. But a healthy person sort of cranks up this area more. This area has to work harder when the spotlight of attention is turned inwards. And it seems that people with schizophrenia aren't able to get that extra bit of processing out of this area. And so perhaps that's why they find it difficult to have insight. And if you remember, this was the area in the healthy controls that was related to self-appraisal. And this was the area in our patients where there was less gray matter density. So it's kind of the same area. So you've got a problem with the software and the hardware, and they seem to coincide quite nicely. And then going back to other conditions, this area seems to come up a lot in addicted patients, Alzheimer patients, even cannabis users. This is an area that distinguishes them from healthy controls. But when we go back to the meta-analysis that Marika did, this is the brain structure and clinical insight, and brain activation and clinical insight, recently published. So again, different elements of insight are colored differently, but all of these areas have come up on at least 4 studies. So our favorite area definitely comes up, as well as this posterior cingulate area, but so does these, pretty much the whole brain. So again, our naive attempts to sort of localize insight to one part of the brain doesn't seem to pan out when you look at all the studies. And then when you look at the metacognition studies, it seems to be, again, our medial frontal areas are definitely coming out in the meta-analysis, but also these other cortical areas, lateral frontal, superior parietal, and the lateral temporal lobes. So again, most of the brain seems to be contributing a little bit to this complex phenomenon that we call insight. So just to finish off, does that lead to any therapeutic avenues? Well, this is the technique of TDCS, transcranial direct current stimulation. It's a very simple and non-invasive technique where you just pass a current through the brain, but you don't feel anything. So you can wear this sort of thing for a few hours every day, and it just slightly alters the activation kind of spectrum across between the 2 electrodes here. So it slightly boosts activity in the frontal cortex. And amazingly, there's now 13 studies that have looked at this in relation to insight. And you can see that there is a bit of a pattern, emerging, that TDCS to this part of the brain is improving insight in people with schizophrenia. So it's not necessarily improving the other symptoms of the disorder, but it is having a beneficial effect on insight. So whether that pans out as a treatment we should be offering our patients remains to be seen, but it's a very interesting link between neurophysiology and insight. But I will just finish by reminding us that it's not all about the brain. So this is just a study showing that what your caregivers and your family believe is wrong with you correlates very strongly with what you believe is wrong with you. So there's clearly personal, family, cultural effects going on as well as what's going on in the brain. So in summary, we've shown that lack of awareness of deficits affects neurological and psychiatric patients in different ways. It's clearly clinically relevant, and it's not uniform. This idea of metacognition, the confidence we have in our judgments of perception and memory, etc., is something analogous to insight, and we can study it in healthy people, and it seems to involve some of the same brain regions that we might expect to be involved. Patients with schizophrenia with poor insight have gray matter deficits, especially in the frontal regions, but also in posterior medial regions, and cortical thickness seems to be important. Functional imaging in healthy people suggests that we have a midline cortical self-appraisal system, and possibly people with schizophrenia who struggle with insight are unable to get the maximum activity out of that system. In people with neurodegenerative disorders, multiple regions seem to be involved with their awareness. Frontal areas, yes, but also temporal and parietal. But not to forget that insight is a bio, psycho, and social phenomenon, and more the interesting for it. Thank you very much. Oh yeah, and here's a plug for my book that's a non-technical book that sometimes talks a bit about insight.
It's a great book, I read it.
We should get a quote from you to add to that.
So do you think frontal neuromodulation would help Donald Trump?
Well, is he mad or just bad? I don't know. He certainly has all the super confidence of a person with very poor insight, despite his low intelligence and low accuracy.
That's the explanation, yes. Any questions?
Tony, thank you. That was great. Do you think that not having insight could be a good thing for some people?
Well, this comes up quite a lot because in another talk, I can talk about how mood and insight are actually very closely related, both in neurology patients and in psychiatry patients. And the way around it is that people with good insight tend to have low mood. People with poor insight tend to have high mood, good mood. So people say, well, yes, I mean, that goes without saying. If you have insight into your illness, you know, I'm suffering from schizophrenia or Alzheimer's disease, of course I'm depressed. Who wouldn't be? But it may not be that way around. It may be that when you're a person with low mood, you're not like Donald Trump. You see the world a bit more realistically, and including your own abilities, faults, weaknesses. And it's when you're in a low mood that you actually see the world for what it is. Some people call this depressive realism. So I'm not at all sure which way around it is, whether insight is making you depressed or depression is giving you a bit of insight. But there's clearly a close relationship.
Tony, there is a question from online, so I'm going to read it with glasses. Excellent presentation. My questions. One, is there any difference between lack of insight in psychosis versus in neurotic illness such as OCD or somatization? And the second, what is the treatment implication in latter cases with poor insight?
Well, it's much easier to talk about insight in something like psychosis, because at least there's a consensus that some of the delusions and hallucinations that are happening, they really are part of the person's inner world, and they're not something that we share. So you can say, so there's a bit of a consensus about what's really happening and what's happening in the person's mind. So I think it's justified to talk about insight. But when you get to more neurotic conditions, and a person says, you know, I don't like being in crowded places. It makes me feel as though everyone's looking at me, and it makes me very self-conscious. is that, we'd say, well, that's social anxiety. But would we say that if they just say, no, I just don't like being in crowds, I don't think that's an illness, would we be confident to say, no, you lack insight? Or would we just say, well, you're just attributing the way you feel in a different way? We give it a label, social anxiety, but it's not like a very definite biological state. So I think when you're talking about insight in these other conditions, you've got to be a bit careful that you're not just saying, well, doctors believe that this is an illness, and if you agree with the doctors, we're going to say you have good insight. And if you disagree with the doctors, you have poor insight. I think we can justify that a bit better with psychotic disorders and dementia, but not so much with the neurotic disorders. On the other hand, I still think it is quite useful, especially in things like OCD, eating disorders, alcohol dependence, for example. I think it's very relevant to talk about, well, does the person see this as a problem? Not necessarily as an illness, but do they see it as a problem? Do they see it as causing an impairment? Do they underestimate its effects? And there you can get something that is a bit like insight. And I think you can work with that therapeutically to good effect. Hope that answers the question.
Tony, I actually have a question. When you started and you presented some of the anosognosia in neurological condition, and you said that it looks like when you just have a visual impairment, you can locate the lesion in the occipital cortex. When you have lack of awareness of your lesion, the area is greater, and there is almost like an area of control for. And of course, when I think about schizophrenia, and I think about the cluster of symptoms, you can have abnormal perception, which can be auditory, visual, then you have the thought processing component. So in some way, if we think in the same way for psychosis, it doesn't surprise me that the part of the brain involved is so much larger. But have you conducted yourself or other people studies in, say, delusional disorder, or people that predominantly have auditory hallucination, to see if that sort of spread over more area of the cortex becomes more focused, so it remains broader?
No, that's a very good question. I understand what you're saying. If this will go back. No? So what they've tried to do here is not what you're saying, which is, okay, what about people with predominantly hallucinations or delusions or thought disorder? But they've taken different aspects of insight, attribution of symptoms, awareness of illness, need for treatment, to see whether these correspond to different brain areas. And so the pink one here is need for treatment, and that does seem to be a bit different from this general awareness of symptoms. So there may be a way to subdivide it, but no one's done what you've said, which is look at particular symptoms and then see whether the insight into them is localized. But I think you're right. If it's like neurology, you should find that people with predominantly auditory hallucinations would imagine that they have problems in the temporal cortex, and that people with poor insight into hallucinations probably have dysfunction in and around that region. So very testable hypothesis. I'm going to steal that idea.
Thanks, Tony. I had a question. How do you think the concept of reality testing or impaired reality testing relates to insight? Is it sort of flip sides of the same coin? I sort of see it with a psychotic person. The primary problem is they can't tell what's real and what's not real. and then that means they don't understand they've got an illness rather than the other way around. Is there a relation, do you think, or are they separate processes?
Yeah, I think it's a very related concept, and I would see that what you're calling reality testing very much in relation to what I call the relabeling of symptoms. So I'm seeing something or I'm hearing something, and then I'm wondering, is that really happening in the world, or is it happening just in my head? So that's kind of what reality testing is. Or was that a dream, or did I really see it? So I think it is very much central to what I'm calling insight, particularly that relabeling of symptoms idea.
And Tony, you get the prize for the most question from the online people. Another one.
Okay.
Is it prudent to add an antipsychotic, maybe low dose, if we could not improve insight through psychological intervention in a person with OCD, with absent insight, delusional belief?
When you look at the effect of medication in psychosis, specifically on insight, you find, not surprisingly, that people's insight scores improve when you treat them with antipsychotic medications. But then everything is tending to improve. The delusions are getting less strong, the hallucinations perhaps less commanding. So you would expect insight to improve. So you could say antipsychotics improve insight, but that's very much related to their effect generally in psychosis. I think in the case of OCD, it is very interesting how some people with obsessions, it's where supposedly, as we're taught as students, reality testing is intact, to use that terminology. So the person says, I have to wash my hands 30 times to get rid of the germs. I know I don't really need to wash my hands 30 times, but I just can't help it. But they get to a point where sometimes they're saying, well, actually, I'm not so sure anymore. Maybe I should be, maybe I will get an infection if I don't wash my hands all those times. So the reality testing starts to break down, and the OCD patient starts to be called OCD without insight. And that's a classification that the OCD world use. Whether you can then make the further leap and say, that means antipsychotic drugs will help with the insight, I think it might do. It's purely an empirical question. It might be because the person is really now more like having a delusion than having an obsession, in which case, of course, the antipsychotic medication is worth trying in that case.
So what would be your general view of asking patients to, across the spectrum, to rate their own symptoms and the utility of developing instruments for having the patients do that? What do you think about that?
Yeah, I think a lot of, well, so again, in the old days, we were taught patients with psychosis, they don't have any insight. You know, it's not, in a way, it's not even worth asking patients what they really think. Thankfully, we've moved on from that. And we now know that it's very, very instructive to ask patients what they believe and their experiences. And they often have a great deal of insight into them. And you can see what Aubrey Lewis called the struggle. You can see that in front of you as the person is struggling to understand, is this really real? Should I give in to these ideas, or should I try and anchor myself to what other people believe? So I think in many cases, the patients do have good insight despite having a psychosis. Obviously, at the extreme ends, it does break down, and their view of their condition diverges from the clinician's view.
just a short comment on the OCD and antipsychotic question. As far as I know from my education, and one of my teachers was an OCD expert, it is not very recommended to give antipsychotics to people with OCD, even in the case of OCD without insight. In the 90s, there was a hypothesis, there's like an overlap between psychosis and OCD, but that has been, as far as I know, rebuked, and many antipsychotic medication can worsen OCD, basically. So if one is very sure that it is OCD and not psychosis, which can be very difficult, if one is pretty sure that it is a case of OCD, I think it would not be prudent to give antipsychotics,
Okay.
but to rather
Thank you.
refrain
Yeah.
from them.
I take that. I don't, these aren't patients that I see, and I wouldn't claim any expertise. So, thank you for that update.
The guidelines do suggest in treatment-resistant OCD that you do prescribe certain antipsychotics, but not all. But it's an augmentation.
And it would definitely help Donald Trump. So, thank you very much, Tony. It was a great talk.
Thank you.